of interest are clinical profile and mutation analysis of MEN1 pituitary disorders, clinical profile and genetics of young onset diabetes. Thank you, ma'am, for chairing this session. We also have Dr. M.S. Sheshadri, who is currently the senior consultant at the Department of Endocrinology in Narovi Hospital. But more importantly and closer to us, he's the founder of the Department of Endocrinology and the former head at CMC Vellore. Sir has done many groundbreaking research and has won numerous awards and accolades over the span of his illustrious career. Sir is also an excellent clinician, and his areas of interest include medical education, clinical medicine, and oncogenic osteomalacia. Thank you, sir, for being here today. We'll go ahead with our next talk. This is by Dr. Nitin Kapoor. He is currently a professor at the Department of Endocrinology here at CMC. He's one of the top 2 most influential researchers worldwide, according to the Stanford University. Has received multiple awards, including the A.R. Seth Gold Medal. He has a H index of 29 with over 350 publications. His areas of interests are endocrinology and expertise in obesity research, including clinical and genetic indicators. Today's talk is on the changing paradigms in effective obesity management. Thank you, sir.
Thank you for that kind introduction. And right at the onset, I'd like to thank the organizers for having me here today. It's indeed an honor and privilege to be presenting in front of my teachers. The topic that has been given to me is changing paradigms in the effective obesity management. A lot has happened in the field of obesity in the last 10 years. And in the next 20 to 25 minutes, I'll try and cover this topic by simply answering 4 questions. I'll try and answer how, why, where, and what. So we'll see how the obesity landscape overall is changing globally in India, even in the state of Tamil Nadu, how things are changing with respect to the phenotype, with respect to the prevalence and the problem statement of obesity. We'll look at then why do we need to change our conventional ways of assessment of not only the severity of obesity, but also the cause of obesity, understanding the comorbidities of obesity and how this has changed over the years. Third, we'll move on to the probably the important aspect, where the newer treatment strategies are taking us in the future. A lot has happened, a lot of newer drugs, something that we've never seen in medicine in the last several decades. In the last 5 years, we've seen amazing progress in the management strategies of obesity. And just before I conclude, we'll just say what the recent guidelines have to say about obesity management. So starting straight with the how the obesity landscape is changing, and I think all of us would agree that obesity has reached pandemic proportions globally, as well as in India. When we look at data from Vellore, this is a study that was done by my colleague, Dr. Rahul, almost 10 years ago, in school children in Vellore. This was done in 4 schools, 2 government, 2 private, between the age of 12 and 16. And what was surprising, that about 30% of school children in Vellore had obesity. Now, Vellore is not a first-tier city, not even a second-tier city, but still 1 in 3 school children in Vellore have obesity. So this is really staggering, and this is almost a decade old data. When you talk of adults, again, what we noticed was that, again, data from Vellore, so from the BBC, again, a rapid increase in obesity, especially in women. Even in the elderly, another community-based study, we saw that the prevalence of obesity in elderly women in Vellore is also big. When we look at national data, this is data from the National Family Health Survey 4, 35 to 40% of the Indian population was overweight and obese, but we look at the state-wise breakup. And again, something that was striking here was that the prevalence has rapidly increased in men. You know, the prevalence is as high as 70% increment, 75% increment in men in over NFHS 3 and 4. NFHS 4 was a couple of years ago, then came NFHS 5, and whatever these numbers were in late 30s now became early 40s. So you see in 5 years, what was 36, 37 has become 42, 44. So such a rapid increase in the prevalence of obesity. But all this data of prevalence of obesity is based on BMI. We know from literature before that BMI is definitely not the best indicator, especially for our population. We tend to have much higher body fat as compared to a given BMI. Another community-based study from Vellore looking at close to 3,000 people, when we looked at the prevalence of lean diabetes, people who don't even have obesity, don't even have a normal BMI, but lower than normal BMI, what was found was that about 5%, 1 in 20, had new onset diabetes despite having lower than normal BMI. So clearly, BMI is not the best indicator for our population. We looked at what is this phenotype called this normal weight obesity, wherein people have non-obese BMI. People are not obese by BMI, but have high body fat percentage. And again, to our surprise, 2/3 of the people who have a so-called with a normal BMI had high body fat. Why this phenotype worries us? When you look at the prevalence of diabetes, hypertension, and dyslipidemia, in this cohort of normal weight obese people, we find that this is at par with those who have obesity and significantly higher as people who do not have high body fat, irrespective of their BMI. To make things worse, when we follow up these patients, and this is through a lifestyle intervention at the end of 2 years, we find this phenotype of normal weight obesity is very, very resistant to change. Very minimal improvements in cholesterol and blood pressure. And in 2 years, we find that this phenotype doesn't do well. We've just got funding and we just completed data analysis for a 10-year follow-up of the same cohort. And we've just analyzed the data, presenting this in IDF early next year. But in short, if in one line I have to summarize, I would say that this phenotype of normal weight obesity, 10 years down the line, tends to do extremely bad. About 70% of them change into florid diabetes as compared to only 10 to 15% of the non-obese normal fat people. So definitely this phenotype requires recognition in our practice, and we cannot ignore it. So that's the first part. We see that the obesity prevalence is increasing in India very, very rapidly, and our phenotype is very different. Our phenotype is more resistant to change, and overall, in time, it doesn't do well. This takes me to the second part of my talk as to why we need to change our assessment strategies. And there are 3 things in assessment that I'd like to talk about. Assessment of the severity of obesity, how we do that in the clinic. Assessment of the root cause of obesity of our patients, and also assessment of the comorbidities. Let's start with assessment of obesity per se, and we know there are several obesity indicators that are available in clinical practice that we can use. Again, BMI has been the most conventional indicator, and we know that the BMI cut points for South Asians are much lower than the West. Again, from literature, we know the waist-related parameters. The central adiposity is, again, something which is more relevant to our population, and more recent data tells us that, yes, assessment of body fat percentage is something which is helpful. There are surrogate measures for body fat assessment as well. But a long story short, as of today, assessment of obesity is moving away from these numbers. Today, we don't want to say that, yes, you are 3 kgs less than last time, so you're doing well. Your weight has increased by 1 kg, so you're not doing well. So it's not the kgs that we need to look at. It's not the numbers, but we are looking at more comprehensive staging systems of obesity to really assess how severe the obesity is. And one such staging system that has been endorsed by most national guidelines is the Edmonton Obesity Staging System. Now, what is the staging system? It takes into account 3 factors: the medical, mental, and functional status of the patient. So if I have in my OPD a patient who's got a BMI of 37, but has severe osteoarthritis, patient comes to my OPD on a wheelchair because of obesity, that patient would directly probably lead on to stage 3, because that patient has severe osteoarthritis, which is like an end organ damage that the patient has already developed. I may have a much severely obese patient in terms of BMI, somebody with BMI of 42, but the patient says, doctor, I'm totally fine. I have just pre-diabetes, no other problems, I'm doing well. So that patient would directly come to stage 1 obesity, despite having a significantly higher BMI. Now, why is the staging system better than BMI? And this is what we learned from the NAINS database follow-up. They followed up for 15 years, and we see that if we look at BMI, we cannot predict mortality. But if we look at the comorbidities and a staging system like EOS, we are able to predict mortality in a much, much better way. And therefore, most of the Indian guidelines have also endorsed the usage of EOS in our clinical practice. When we looked at our own data from Vellore, the obesity clinic here, we find significant number of patients do belong to stage 2 and stage 3. And the Endocrine Society of India National Guidelines for Obesity Management today not only mention about the EOS, but also tell us about how we manage obesity at each of these stages. So that's how the assessment of obesity in terms of its severity has changed. But also what has changed is our understanding about assessment of comorbidities of obesity. And I think as physicians, all of us are very well trained to understand and evaluate the metabolic problems of obesity. But what we often miss, or what we should not miss, is the other aspect, the psychological aspects of obesity, the mechanical aspects of obesity. Again, when we look at data from our clinic, the obesity clinic here in Vellore, we find that about 30%, that is 1 in 3 people who walk into the obesity clinic, actually have an underlying psychological problem that needs to be addressed. So again, looking at the mental problems is important. Looking at mechanical problems is equally important. Not only obstructive sleep apnea, looking at their bone health, all of that also is very important in contributing to the poor quality of life in these patients. The third aspect of assessment in trying to assess the root cause of obesity, believe me, with all the understanding of obesity that has happened in the last decade, we now truly know that it's just not the patient's choice of eating more and walking less that is causing the obesity. This is a much more complex pathophysiology in the hypothalamus, and we really need to recognize that, need to try and understand what's really going wrong with the patient. And a lot of emphasis has also now come in the genetic aspect of obesity, again, with the coming of NGS and genetic tests being very much available at a cheaper price. We are able to do testing and identify these patients who have a genetic cause of obesity and identify them much easier. This would be a simple criteria, at least 2 out of 8. If present, yes, we should suspect a genetic cause, a monogenic cause of obesity. And why this is really taken off as something very important is today, treatment is available. If you find out somebody who has a monogenic cause, drugs like setmelanotide have known to cause 20 to 30 kilograms of weight loss, because these are specific drugs which work at the mutation that the patient may have. And believe me, these genetic cause, the patients who have a genetic cause don't really classically come under the typical, mentally retarded or challenged or somebody who's not doing well. These children are very intelligent. They have severe obesity. They have hyperphagia, but it's only a case of being recognized and treated properly, and makes a huge difference for them. A lot of understanding has now happened that all our hypothalamic regulation, which gets disrupted in obesity, is something that we learn about, and therefore a lot of interest has developed more recently in all the hypothalamic causes of obesity and how these newer drugs that I'll talk about work in this phenotype. So with this, we move on to the third aspect of my talk, talking about the newer strategies of management. And before I talk of the newer drugs, let me emphasize as to how our dietary approaches for obesity have changed. In this slide, I've tried to summarize most common diets which are often prescribed for obesity, and broadly, we could classify them into 2 parts. Either it would be a calorie restrictive diet or a diet that changes macronutrients. But believe me, again, what has changed in dietary prescriptions is gone are the days that you give a pamphlet to a patient as do's and don'ts for obesity management and expect that patient to lose weight and come back in your clinic. That doesn't work. What is recommended now is a person-centered approach for obesity management. You try and understand the kind of dietary practices, the culture of the patient, and then try and suggest a diet which is specific for that patient rather than give a common diet that works for everyone. Which diet is good, which is not good? By and large meta-analysis, large follow-up studies, including this particular study, which was published just last month in Cell, has clearly shown that there isn't really much difference in terms of what the impact of any diet would be. It just depends on how much calorie reduction has been achieved, irrespective of the type of diet. And that's what really determines the weight loss. In this particular diet, low carbohydrate diet fared little better than time restricted eating, but by and large, the quantum of weight loss was similar. What has been emphasized again, time and again, especially for us in the Indian setting, is that the protein intake in our diet is grossly less, and that is something which should be increased. Again, when we looked at our own data from the obesity clinic, and all these patients who enter the clinic have a BMI cut point of 35 kilograms per meter square, and all of them are taking many calories excess in what they should, but still they don't meet up the amount of protein that they should be eating. So yes, protein intake is something that we need to emphasize. A lot of literature also on fiber intake. Earlier, fiber was predominantly talked about in diabetes, but also emerging role in obesity. And again, something that is new and really emerged in obesity management, I think all along, we've been talking a lot about macronutrient change in obesity, but emerging data is also telling us the importance of micronutrient change, the role of B12, folate, iron, also in management of obesity. And a lot of work from Dr. Yagnik's group in Pune has now shown how changing the micronutrient composition is also something very important for management of obesity. Again, recent literature talking about not only diet, more recent papers talk of looking at dietary patterns in general. It's just not one food item increase or decrease. You're trying to study the dietary patterns and how they impact the cardiometabolic risk in people with obesity. A lot of work recently has also happened in the field of prescribing meal replacement therapy after the paramonial work from Dr. Roy Taylor's work in reversal or remission of diabetes. Again, earlier on data was available only for 1 year, but more recently we have data for 3 to 5 years talking as to how meal replacements can be helpful. Again, this is something that has been endorsed by the national guidelines. A lot of emerging Indian data as well as to how giving very low calorie diets can essentially improve the metabolic parameters. A lot of different subdivisions in this particular study that we are collaborating with Emory, trying to look at how very low calorie diets in people with isolated IFG and severe obesity also have a very good impact. Talking about the medicines that are available, again, when we look at what has been approved so far, we've not really had very powerful medicines for obesity management. Orlistat is something which is available, causes about 2 to 3 kgs. The side effects are not easy to tolerate. We have liraglutide, which has been off patent now, but we don't have 3 mg, which is ideally recommended for obesity. We have what is available is 1.8 mg. An injectable semaglutide 2.4 mg, which is approved for use in India, has not been launched. And so at this point in time, we do not have many medicines, but many of these will be launched in India in the next couple of months. I think the game changer here was this paper, which was published in NGM in 2021, the STEP 1 trial, the first trial of using injectable semaglutide, which first time showed that a drug could cause weight loss to the scale of 15%. Thereafter, several trials, there's 4 STEP trials shown here, but as we talk today, 19 STEP trials have been published as looking at the impact of semaglutide on different aspects of obesity, and all of them showing very significant weight reduction with the help of this drug. The important data which has more recently come up about the use of these drugs is that not only the weight comes down, the waist circumference comes down, but also now we have body composition data. There was a lot of concern that these drugs cause a lot of weight loss. They do cause fat loss, but do they also cause significant muscle loss? They do cause muscle loss. When you lose weight, it's not possible not to lose muscle, but the muscle loss is relatively less, and the visceral fat also comes down. The next molecule, which is probably going to be the molecule that will be launched first in India in the first quarter of next year, is tirzepatide. It's a GLP-GIP agonist, initially used in diabetes in all these 5 SURPASS trials. But then in diabetes, what was found was that a lot of patients lose significant amount of weight. About 40% of patients in each of these trials lose about 15% of weight, therefore opening the way for obesity as an indication for this drug. So these were the SURPASS trials for diabetes, but then came the SURMOUNT trials, and this is for the first time that we had a drug that caused about 20% weight loss over a period of 2 years, something that is just reaching what we could achieve with bariatric surgery. Again, several SURMOUNT trials have been published after that in people with diabetes, in those after lifestyle intervention, and the number remains the same, about 20% weight loss with this drug, irrespective of the indication. A lot of trials are in the pipeline. SURMOUNT OSA, which was OSA trial, which was published earlier this year. There's another one for fatty liver, another one for heart disease. But in this particular slide, in this review, we summarized all the drugs that are currently available or in the pipeline for management of obesity. And if you ask me, which is the most powerful drug at this point, that is a triple agonist of GLP, GIP, and glucagon agonist, retatrutide, causing something to the scale of 25% weight loss in people with obesity. And now newer indications for these drugs are also being sought. These drugs are being looked into with respect to the cardiovascular benefit. They've got approvals for usage in patients with coronary artery disease or heart failure, individually, irrespective of obesity and diabetes as well. And several of these drugs are in the pipeline. Well, till these come, bariatric surgery still remains the gold standard, if I may call the king of obesity management so far. A lot of development has happened in terms of the intragastric devices also that we use. So with this, I move on to the last and the smallest part of my talk, where we look at what we have through the recent guidelines for obesity management. And again, guidelines have changed several-fold over the last years. What initially used to be a very BMI-centric approach, today these guidelines are more complication-centric, more person-centric. I think one of the most comprehensive guidelines for obesity management were published by the Canadian Obesity Network. And I think a lot of focus, this guideline runs into 200 pages of different sections, but I think a lot of focus has been emphasized on not to just look at weight loss, but look at patient-centered outcomes to see how quality of life of these individuals improve. And this is something that we often don't look at. When we looked at this data from our center, again, the quality of life of women with severe obesity is dismal, even in our country. And this is something that we really need to look at more carefully. There have been national guidelines from India, both by the Endocrine Society of India and by the RSSDI. And if there's one point that I'd like to highlight, what has really changed in the way these guidelines are written today is the importance of how we communicate with these patients with obesity, how we make sure that we use the right kind of terms when we talk to these patients, not to stigmatize these patients, but also use more scientific terms. It's another study from our center where we looked at how stigma is associated with obesity, and I'm sure all of us agree that people with obesity are often stigmatized. But what this study also showed is that obesity also happens because of the stigma. So people who are stigmatized tend to develop poor eating habits and then lead on to more obesity, and this is a vicious cycle. Many of the guidelines, not only for obesity, but even diabetes, have changed. They've become more obesity-centric. Today, obesity comes top after looking at diabetes management. More recently, last year, we had the guidelines for pediatric obesity management, and earlier this year, the Indian Academy of Pediatrics also mentioned, have published their own guidelines for obesity management, again, in a very similar way, like for adults, expanding the spectrum of obesity, looking at other comorbidities. Very sad to see that, they're asking us to screen for fatty liver disease, for obstructive sleep apnea, even in children. But yes, obesity is becoming a big problem in children as well. So friends, with this, I will stop here. These are the 4 things that we discussed. We looked at the problem statement of obesity, how things have changed over time. We've looked at our phenotype, how it is different. We looked at how assessment of obesity needs to change from what used to be a BMI-centric approach to a more complication-centric, a more in terms of a staging system of obesity that we need to bring in our practice. We looked at the comorbidities, not only to stress on the medical comorbidities, but also to look at the psychological aspects and the mechanical aspects as well. Looking at newer management strategies, yes, dietary changes are important. more emphasis on calorie reduction, more emphasis on protein, fiber, but also data on micronutrient management is emerging for dietary management of obesity. Newer drugs are coming in, and definitely they are highly effective in reducing weight and reducing the comorbidities. And the guidelines really endorse that when we talk to these patients, we have to be sensitive. We have to make sure we do not stigmatize obesity and just not blame the patient for eating more and walking less, and understand that obesity is a chronic disease. I'd like to stop here. Would be happy to take any questions. Again, would like to emphasize, as Dr. Felix said, we invite you all to our conference in January. Thank you.
Thank you, Dr. Nitin. The Q&A session will be at the end of the endocrinology track. We're taking for the audience the